We're going to take some questions from our audience. First question, what is the maximum dose of etanercept you have used in clinic?
Well, I think you, Mary, could probably respond to that probably a lot better than I can.
We have had to use 50 milligrams 3 times a week on several of our patients, most of them being the larger patient. Second question, I think this one's for you, Dr. Mentor. Explain PASI 75.
You know, PASI 75 is used for all clinical trials. A PASI score is seldom done in clinical practice. It's really not all that difficult. You divide the body up into 4 parts, head and neck, 10% of the body, trunk, 30% of the body, upper extremities, 20%, and from the hips, including the buttocks, the legs, 40%. So what we do erythema, induration, scaling on a 0 to 4, and we put this all together in a scoring system and create a PASI 75 score. PASI 75 means if the PASI score at baseline is 20 and you get a 75% reduction, mathematically that means PASI score comes down to 5. So we want to see that. So it's slightly more technical, but certainly statistically more valid than just looking at a patient like we have on the slide, for instance, and saying this patient probably has 50% body surface area. And looking at the erythema and the induration, the scaling gives us a better idea of how this patient is progressing.
Thank you, Dr. Mentor. Our next question, what impact do you think emerging agents will have on psoriasis, and do you think that they will have a clear advantage over the currently available TNF inhibitors?
You know, that's a very good question. I do believe, as I said when I was finishing my talk, is that the new IL-17 agents, and there are IL-23 agents coming down the pipeline as well. Ustekinumab, Stelara is IL-12-23, but there will be specific IL-23 agents in addition to the 3 IL-17 agents. The results in clinical trials are dramatic. Certainly the PASI scores are in the 75 scores on the 80 to 90%, and we're now talking PASI 90, where PASI 90 scores on the 60 to 70% mark. And as I said to a colleague of mine recently, I said PASI 75 may become passé when PASI 90 becomes the marker for our psoriasis patients. The question is, what do they do in joint disease? And I think a study just published in the New England Journal of Medicine with one of the IL-17 drugs, brodalumab, showed that there is a slower onset of action in joints than the 3 TNF-alpha agents do, and may not reach the so-called ACR, American College of Rheumatology 20 score, that the TNFs. So I think it would be nice to have these drugs available. I think they have a tremendous opportunity because we have multiple patients who are not responding to our current drugs. But I am certainly hoping that in 5 years, Mary, if you and I are still around in 5 years' time, we can take the blood of each individual patient, do what we call pharmacogenomics, screening genetically, and target individual drugs to individual patients. Instead of saying, let's try this, we'll have drugs that definitively we know have a better chance of working.
Boy, that would be an answer to our prayers, wouldn't it, Dr. Mentor?
Would.
Our next question. What about safety profiles of biologics for psoriasis based on registry data? Do they agree with clinical trial data in terms of risk for infection and malignancy?
Again, a very important question. You know, clinical trials are clinical trials. You cannot put a patient into a clinical trial with a prior cancer, even though a female may have breast cancer 15 years ago and cured, that patient is not eligible for a clinical trial. So there's a tremendous amount of exclusions in clinical trials. So our real world is basically driven by registry data. The rheumatologists have had registries for a lot longer than we've had. The Wolf registry, for instance, has 15,000 patients in it, 10 years of data. So I do believe when you do a registry and it's appropriately managed, and you see patients twice a year, and every conceivable infection, every conceivable medication is put into the registry, that long-term these registry data are very significant. The best registry in the world is the Danish registry. Every patient born in Denmark from day 0, from day at birth, is put into a national registry. And they now have some wonderful data particularly for psoriasis, showing the issues relating to TNF-alpha agents, for instance, improving cardiovascular issues, improving them definitively, and they've got very good data. We have registries here. We have the SOLAR registry, which now has 12,000 patients in it, okay, across the whole spectrum of diseases. There are individual drug registries for etanercept, for adalimumab. The British Association of Dermatology has a 5,000 patient registry, which will grow as we go on. The Europeans have registries. My Latin American colleagues, we've helped create registries. So I do believe, and I'm sorry being a little long-winded in my response to this thing, that registries will give us appropriate data for the real world and not just for clinical trials.
Thank you. Dr. Mentor, do you always use methotrexate with Remicade?
You know, that's a very difficult question to answer. Do we always use methotrexate? If I was one of my colleagues, Bruce Strober, Craig Leonardi, they start with methotrexate ab initio every time they start Remicade. What we did is we published a study a few years ago where we took about 125 patients who'd been on Remicade for longer than 1 year to see what percentage of them had required methotrexate or a change in the dosing schedule of Remicade. There was still about 35 to 40% of patients up to 5 years into their Remicade who were totally clear without methotrexate and without a change in dosing. So yes, rheumatologists tend to use it because it's part of their studies where methotrexate is on board in the majority of cases. I tend not to do it ab initio. Maybe I'm being a little conservative, but as soon as a patient shows any potential loss of efficacy, I add methotrexate in low dose. So it's a personal decision.
Thank you. Our next question. Most psoriatic arthritis patients are heavy, majority above 100 kilograms, and most time with comorbidities like diabetes. Infliximab contains 200 milligrams of sucrose. Can we still use infliximab in psoriatic arthritis patients with diabetes history?
I think the answer to that is categorically yes, even though, as you correctly point out, a good question, that there is sucrose within the infusion and approximately 500 mLs of infusion is used for each infusion. Certainly, there does not appear to be any increased risk of diabetes, and almost all studies have shown that this control, whether it's on oral hypoglycemics or insulin, is not lost when patients are put on infliximab.
Okay. Any caution in the use of infliximab in a patient with idiopathic peripheral neuropathy, non-diabetic related?
First thing I would do is I would consult with one of my neurology colleagues. If there was any form of neuropathy and it was idiopathic and there was no family history of demyelinating disorders such as MS, I would certainly get, and I have a close colleague in the neurology field with whom I work who understands infliximab and all the TNF-alphas, understands the MS situation. I would be comfortable continuing if it was idiopathic, yes.
Thank you.
The big question that relates to, and we have a paper in press relating to that, if you have somebody you want to put on infliximab whose sibling has MS, or his first cousin, or his uncle or aunt, or her whatever close family member has MS, our guidelines say no. I do believe that is not correct, that I'm comfortable, provided the patient is appropriately evaluated at baseline by my neurology colleague, that I can start infliximab accordingly. Or any of the other TNFs as well.
Okay. One of our physicians has a young patient, a 20-year-old woman with multiple sclerosis and psoriasis. What would be your treatment recommendation for her psoriasis? In other words, can some treatments worsen MS?
Well, I think all the evidence is that TNF-alpha agents, adalimumab, etanercept, and infliximab, can have a negative effect on MS. So certainly those would be contraindicated. Our systemic agents, oral systemics, methotrexate, has no evidence to suggest. We have 40 years of evidence using methotrexate. So I'd be comfortable, if appropriate, to use that. But ustekinumab certainly has no negative effects. Stelara has no negative effects on MS. So that would also be one of my first treatments.
As a family physician, at which point do you recommend referral to dermatology? And what can family practice doctors do prior to referral? I have used topicals, combo with methotrexate, with, of course, doing routine labs. But I wanted to get your opinion.
You know, there's not enough dermatologists and rheumatologists to go around to treat all the psoriasis patients worldwide. And I think the data to date shows that 50% of patients with psoriasis in the past year have not seen a dermatologist. So I'm very much in favor of working in collaboration with family physicians, internists, endocrinologists. I think we in dermatology need to do this more frequently. And certainly it is vitally important that somebody with the insight, like the questionnaire for this talk, does feel comfortable using appropriate topicals and or methotrexate, recognizing that methotrexate in psoriasis patients is a little bit more difficult because of the fatty liver and metabolic issues that cause increased liver functions. But I think if somebody is not adequately controlled, primary care physicians have a very close relationship with their patients, and the patient is expressing concern, and there are visible areas, and their quality of life, their dress, they cannot wear black because they're constantly flaking away, they're itching, they're scratching, they're not having relationships, and those questions are asked, and the appropriate treatments that you mentioned, topicals and methotrexate, is not adequately controlling that patient, then I think a referral is indicated. But I think where primary physicians can play a significant role in our psoriasis population is by looking for the metabolic syndrome issues that I've mentioned earlier. Vitally important that we work in collaboration with our primary care physicians for not only the skin control, but the comorbidities as well.
Thank you. Dr. Mentor, how should clinicians use safety and efficacy data from clinical trials or registries when counseling the patient on treatment options?
You know, now that we have registry data, and actually there's a wonderful publication which I tell all our patients about. It was published in Annals of Rheumatology 2 years ago, in which they did a review. It just happened to be adalimumab, but I think the same thing would go for etanercept and infliximab. They did a review on all 7 diseases for which adalimumab is approved. 74 studies, an average of 9 years of follow-up in these studies, okay, 23,500 patients, and this is how I tell patients, and they looked at every conceivable side effect across all 7 diseases, including psoriasis, for the infections, for the malignancies, for the lymphomas, for the MS, etc. And the evidence now, and it's a very good statistical analysis, that there was no increase over the 9-year period in these 23,000 patients, including our psoriasis patients, of any side effects. So I do use clinical trial data because all patients come in and say, what are you going to do to my immune system, Dr. Mentor? Mary, you hear this all day long. You're going to increase my risk of infections. You're going to increase my risk of cancer. I use the term for our patients, immune modulating, and you and I discuss this. What does modulate mean? Bring it back to normal, not suppress it. And Mary will tell you about this. Mary talks to every one of our patients that we initiate a biologic treatment on. So I do use that data to try and explain to patients, we are trying not to suppress your immune system, we're trying to modulate it back to normal and give them the data to say that we have these drugs for 10, 15 years. We've used them in children. And you know the one thing, Mary does this better than I do probably, is we now can tell them that these drugs have a potential positive effect on their cardiovascular system. Their eyes open up when I mention that to them. Methotrexate as well has been shown to improve. If aspirin improves cardiovascular issues, methotrexate improves it even more. And so do the TNF-alpha agents. So we can talk positives rather than just worry about the negatives.
Education of the patient is everything. Our next question, Dr. Mentor, at what stage do you decide to transition a patient from a topical therapy to a biologic?
You know, a lot depends, as I said in the beginning stages of my talk, on the phenotype of that psoriasis. If it's palmoplantar and in 3 months I haven't got adequate control, then I will immediately jump into a systemic agent or a biologic agent. If it's severe scalp involvement, and I haven't been able to control their scalp involvement with topicals, even though that's less than 5% body surface area, and severe scalp involvement, and it's causing quality of life issues, and people are scratching and scrubbing all day long, they can't wear appropriate clothing, they don't want to appear in public, I will, even for severe scalp, consider a systemic or a biologic agent as necessary. So I think, the old paradigm that I grew up with back 30, 40 years ago when I started my work in psoriasis, topicals first, light treatment second, PUVA third, systemic agents fourth, and then finally biologics, and you had to go through each one of those. Those days, as Mary is shaking her head, are gone, are behind us. We need to start treatment appropriately and not just go through the spectrum of topical agents initially. Certainly, for the majority of patients, topical agents works well, okay, and are adequately controlled, but for a significant proportion of our patients, they do need more than just topicals.
Is it enough to just improve the signs and symptoms of psoriatic arthritis, or do we need to stop the progression of the disease?
I wish we had a marker that will tell us what percentage of patients with early onset joint disease are going to develop further destruction or destruction. We don't have any serological markers. I believe we will have. It's probably true to say that we are speaking with my rheumatology colleagues around the world that up to 60% of patients with early onset joint disease with no radiological changes whatsoever, if left untreated, will go on to develop destructive joint disease. And I do believe one of the big benefits of the 3 TNF-alpha agents is that they prevent further joint destruction. Methotrexate does not. I think we will probably hear in the near future that ustekinumab does, even though it works a little bit less well in psoriatic joint disease. So it is vitally important that we cannot, as I showed in my last slide, with that little child who had early onset joint disease, that has to be stopped in its tracks right from the get-go.
Okay, and this question kind of goes along with it. Do we have any data to support the use of biologics in psoriasis for the last 10 years that have resulted in overall lowering of psoriatic arthritis incidence?
I don't believe if you are genetically predisposed, that you can stop. But on the other hand, by using TNF-alpha agents, as we have for the last 10 or 15 years, patients may never get the joint disease for which they're genetically predisposed. So we don't have good genetic markers. Rheumatologists always tease them, do an HLA-B27. I'm HLA-B27 positive. Fortunately, I don't have psoriatic joint disease. So there's very few genes that we can predict psoriatic joint disease when someone develops skin disease. We will have them as time goes on, where we can predict who is more likely to get psoriatic joint disease. But certainly, to answer the question more specifically, I do believe that the incidence of joint disease has dramatically lowered because patients are not getting it because of the use of TNF-alpha agents.
Thank you. Is there any racial difference in response and side effects to the biologics?
To my knowledge, and as I travel internationally and I've discussed it with my colleagues in Asia, for instance, and Africa, there does not appear to be an individual difference in different patient populations. Even in the diverse U.S., does a Hispanic or does an African American differ in their response versus a Caucasian, for instance? The answer is, at this stage, we do not know the answer, but it does not appear to be. Recognizing there's a very tremendous difference in the incidence. American Indians, for instance, have very little psoriasis ever. Africans from Africa have far less psoriasis. Asians have far less psoriasis. Europeans from Europe and Latin America and the US have the highest incidence of psoriasis worldwide.
How many years can a patient continue on TNF treatment?
Well, I think we've got data now for 17 years, okay, when the TNFs were first looked at in 1997. So we have data on patients who have been on these therapies for 15 years. I talked about the average of 10 years in the 7 disease adalimumab study. So I believe if you have a lifelong disease and you have a drug that is appropriately helping a patient, there does not appear to be any rationale at this stage for discontinuing the drug. I'm hopeful that we may have inflammatory markers in the years ahead, that we can talk about patients in total remission without necessarily needing to continue the drug. Because every patient says, Mary, I'm clear, why do I need to continue my treatment? And I tell them it's not only for your skin and your joints, but it is for other potential organs like cardiovascular organs to improve it. And I bring up the analogy of diabetes. How many diabetics can stop their insulin with oral hypoglycemic patients, drugs? How many MS patients can stop his or her drug? How many inflammatory bowel disease patients ever get off their systemic therapy? At this stage, we are comfortable with long-term safe control until we have markers that will allow us to maybe interrupt treatment.
Okay. Are there any body skin locations that are less responsive to systemic medications and treatments?
Yes. Scalp, palms and soles, definitively. And I think all patients, distal half of the legs, as you well know, respond less well, okay? So definitely from the knees to the ankles, scalp involvement is always less effective, and certainly, we have to look at the joint disease issue as well.
We're getting down to the end of our questions, but I have one. While pruritus seems to be quite prevalent in the more severe psoriasis patient, how significant of a role does itching play in the milder patient?
I think the majority of patients, if you ask them, will say, my psoriasis is itching. Even one patch itches. You've got inflammation there. It triggers different cytokines released from nerve endings within the skin. So the majority of patients itch. And in fact, in many of our clinical studies, we now have an itch questionnaire for patients, and we can rate the itching from 0 to 100. And the majority of patients are in the 60 to 70 mark for itching. So I do think, and you go to scalp, is there a single patient who doesn't scratch or itch their scalp? You tell me. You know that very, very well.
And can you bring up about how you know if they're right-handed or left-handed? That's always good.
Well, we did a study once to say if a patient, psoriasis is a very symmetrical disease. What you get on the left side, you get on the right side, except in the scalp, because people are scratching with one hand. My son is an anthropologist, works in Africa, and I was with him one day, and I saw an ape scratching with both hands. I said, why don't we scratch with both hands? He says, because we're too busy with clickers and telephones and steering wheels, so we always have one hand free. But the study we did show that if you have a big, thick plaque on the right-hand side, does that mean you're right-handed versus someone has a plaque on the left-hand side? No, it depends on which hand is free. So the handedness does not appear to be significant.